Cancer is a risk factor for delirium, a syndrome that is prevalent in hospitalized individuals and is associated with increased morbidity and mortality. Prevention is more effective than treatment after the development of delirium. Our study validated the use of a tool that predicts delirium risk in hospitalized older adults with cancers or living beyond cancer. So my name is Dr. Ali,
My name is Dr. Magna Vasco.
and we're honored to present our article, External Validation of the Mayo Delirium Prediction Tool in Individuals with Cancer, on behalf of all our team members.
Well, the Mayo Delirium Prediction Tool is a validated delirium risk assessment tool that uses EHR available data to predict the risk of a hospitalized patient with information from the first 24 hours of admission. The MDP tool was derived from a robust data set of over 80,000 individuals and validated in a cohort of over 40,000 individuals. However, amongst all of the diagnoses accounted for in these cohorts, only about 802 or 0.7% of the individuals had a cancer diagnosis. As cancer, as you mentioned, itself is a risk factor for delirium, we wanted to see if the MDP tool was applicable to our patient population at the University of Texas MD Anderson, a tertiary comprehensive cancer center. Our retrospective study looked at individuals with a cancer history hospitalized on either the surgical or medical services. A total of 930 individuals aged 50 or older were included in the study. Through collaboration with colleagues at the Mayo Clinic, we were able to risk stratify individuals into three categories of low, intermediate, or high risk using the MDP tool. We then compared the risk stratification data with a chart-reviewed history of who ultimately developed delirium during their stay.
Ultimately, we were able to validate the MDP tool in individuals admitted to surgical and medical services and who had a history of cancer. The tool performed with an AUC of 0.8, similar to MDP recalibration study. For individuals admitted to the surgical services, the AUC was 0.94. And for those admitted to the medical services, the tool had an AUC of 0.78. For those identified as high risk of delirium, the tool had a sensitivity of 42.6% and a specificity of 94.6%. For those identified as low risk, the tool had a sensitivity of 88.3% and a specificity of 50.5%.
Well, delirium, as you kind of alluded to before, has significant morbidity and mortality associated with it. Its prevention, screening, and treatment can be labor intensive for the healthcare team. What we really envision is that there could be a freeing up of manpower. Instead of spending time screening all the patients for delirium, if we just focused on those who are at intermediate or high risk, which would screen about 53% of admitted patients, we would on our own be able to identify about 88% of those who would go on to develop delirium. If the care team members are able to decrease their screening efforts by half, that really allows for them to have more direct patient care.
For an individual and or caregiver, the hope is that the risk stratification leads to education about early intervention for and prevention of delirium, ultimately decreasing the potential hospital length of stay, risk of future depression, cognitive impairment, requirement of discharge to a high level of care, and mortality. What really makes us excited is the prospect of implementing this tool in the EMR and having it automated to allow for use on a broader scale. Furthermore, we would be interested in dynamic modeling. Our current study only looks at factors present during the first 24 hours of admission. If MDP factors change, for example, someone clinically improves from an infection or develops a bleed, it would be helpful to reassess their risks based on their current health picture.
Well, thank you so much for your interest in our article.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.